Welcome to the McLean Hospital Crafting Support Project Family Webinar Series. So for those of you who don't know me, I'm Dr. Julie McCarthy, and I'm a clinical psychologist and researcher at McLean Hospital. Tonight, I'm very excited to have you join us for a presentation on empowering caregivers through psychosis education and skills training, an overview of the Psychosis REACH direct-to-consumer training program, and an interactive discussion with Dr. Sarah Kopelovich, who is Associate Professor of Psychiatry and Behavioral Sciences at the University of Washington. All right, so first up, as we get started thinking about our agenda for today, first I'll go over a brief overview of why we are all here tonight in terms of the Crafting Support Project. Then we'll go into the presentation on Psychosis REACH, our Q&A, and closing remarks. And before we dive in, I thought we could check in for our first poll to get a sense of who's with us tonight. And so if you don't mind, please answering the poll that I'm about to launch right now, which is just to please describe your role, whether it be a family member, person with lived experience with mental health challenges, clinician, none of the above, or you may have intersecting identities, which we welcome as well. So we'll leave this poll up for a little bit and then we'll close and I'll write a little summary. Okay, I'll close the poll in 3, 2, 1. Okay, so today we have about 93% of our audience are family members. And then we also have people who have their own lived experience with mental health challenges and also people who identify differently. So thank you so much for being with us tonight. Okay, so what is the Crafting Support Project? First of all, if you've been with us before, or maybe this is your first time with us, you might have a loved one in your life, or maybe your own experience with mental health, where you may be working with someone who you feel like needs help, and they may or may not be ready to get the help that they could really need, or maybe they are getting some of that help, but we still need some more support navigating the day-to-day, or really figuring out how to best help people pursue their own recovery as they define it. And so this set of services has really been brought about from the generous philanthropy support that we've received to offer education and resources to people like you who might be looking for more supports to help themselves and their families. So part of this program is what we're doing tonight, our family webinar series, Thursdays from 5 to 6 p.m. We've already had a number of excellent presentations so far. And so now we're nearing the latter part of our programming tonight. And then we have 2 more webinars later this year. And for those of you who may have missed last year, all of our webinars that we completed that were skills-based, largely talking about community reinforcement and family training or craft, are online now for anyone to check out at your leisure. And we also have an opportunity for people who are families who have gone through McLean, particularly if you've had a loved one with psychosis or history of that. Feel free to get in touch if you're interested in up to 8 one-on-one weekly sessions with a coach like myself or someone trained working with me, because we're offering these types of coaching sessions for people who are not eligible for coaching through our research study, but could still benefit from support through at least the end of the year and potentially beyond if we get additional support. Okay, so in just a moment, we are going to turn things over to our presentation today on Psychosis REACH. Before we do, I'm going to do a little poll and then I'll introduce Dr. Kopelovich. So to get a sense of whether or not you've heard of this before or how familiar you are, I'd love it if you wouldn't mind sharing with us your familiarity. So how familiar are you with what's called the Psychosis REACH training program? You're unfamiliar, brand new to that idea, minimally. Maybe you've heard the term before the webinar, but that's about it. Moderately, maybe you've read or learned some details about it. Or maybe you are very engaged in the Psychosis REACH training. Okay. Looks like there's a little bit of a mix in responses. All right. So any final responses can come in 3, 2, 1. And I'm ending the poll now. So about 55%, so over half the folks with us tonight are not familiar with Psychosis REACH, so you are in the right place for sure. And then we also have some folks who are somewhat minimally or moderately familiar, and then a couple who may be very familiar with this excellent approach that I have also completed myself. And so just to introduce our speaker tonight, Dr. Sarah Kopelovich is a licensed clinical psychologist in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine. She's an associate professor in the department and holds the professorship in cognitive behavioral therapy for psychosis. Her current research is specifically oriented toward implementation and dissemination strategies for psychotherapeutic and psychosocial interventions for schizophrenia spectrum disorders. She directs the Northwest CBT for Psychosis Provider Network, serves on the steering committee of the North American CBT for Psychosis Network, and is a co-founder of the Center for Mental Health Policy and the Law at the University of Washington. Dr. Kopelovich is also a co-developer of the Psychosis REACH model, and we are so lucky to have you with us today to share your expertise. So I'll let you take it away.
Thank you. I'm so happy to be here, and I'm definitely in the right place because I'm amongst family members. So it's really nice to be here, and I really want to say thank you to Dr. McCarthy for inviting me to present on this training that I'm just so passionate about. I'm going to go ahead and share a few slides, but I really love the way that Dr. McCarthy has set up this time because at least half of our time together will be spent in discussion with each other. So my ambitions for the time that I have where I'll be sharing slides is just to provide a quick orientation to the intervention, why it's needed, what it consists of, and then happy to follow up in the Q&A on any specifics that you are curious about. One thing I really want to emphasize right off the bat about Psychosis REACH, and by the way, REACH is all capitalized because it's an acronym that stands for Recovery by Enabling Adult Carers at Home. And this was an intervention that, unlike other family interventions for psychosis or for other presenting problems, this was really co-produced by families like you, in addition to clinician experts. So myself, Dr. Douglas Turkington, Dr. Kate Hardy, we all specialize in CBT for psychosis, both treatment development and also training and implementation. And then Akansha Vaswani Bai is a phenomenal counseling psychologist who joined my team here at University of Washington and has really taken over the lead of training some of our family members to become a Psychosis REACH family ambassador. And I'll talk about that role in just a minute. Helen, who goes by Trez Buckland. Trez Buckland is, I actually pulled her out of retirement. She is a educator by training and also has a son, an adult son with schizophrenia, and has become really our lead family ambassador and trains future family ambassadors. And we have a network now of these family ambassadors across the United States. And the reason why we have trained family ambassadors is because we really want this intervention to be co-delivered by clinician experts and experts with lived experience as family members navigating psychosis. And the value that they have brought to this work, both the content of the training and the way that it's delivered, is really just, it cannot be overstated. This presentation actually was developed through a collaborative effort with 4 of our Psychosis REACH family members, Trez Buckland, in addition to Sue Adams, Amy Toole, and Denise Winter. So I want to give them a big shout out. And then I just want to start by grounding us in this beautiful quote that we found online by a therapist and writer who goes by Meeting Myself Again on social media. And she writes, many of us have never witnessed the move from conflict to repair. Many of us have never witnessed communication through conflict rooted in curiosity, kindness, understanding, and a will to change. Many of us have almost exclusively witnessed conflict as a catalyst for emotional explosion, reactivity, avoidance, and in the long term, growing feelings of alienation, coldness, and distance. Is it any wonder we are scared of conflict? It is entirely protective and logical to avoid that which has been the propeller for relational disconnect, to walk toward conflict, a place which has been recognized as the source of undoing, of isolation, of rage and harm, takes bravery. We find our courage from knowing that conflict itself is not the source of the pain, but a symptom. And the medicine is in a different movement forward. We are really out here trying to engage in a way that many of us have never even seen, let alone learned how to do. May we be gentle with ourselves as we learn how to show up differently. I think this is such a beautiful quote that captures what we try to teach family members, which is that we're learning a different way of approaching communication, and we're approaching it through curiosity, kindness, understanding, and a will to change. And as we learn these new patterns of behavior and replace old patterns of behavior that are no longer working for us, or maybe they never worked for us, it's a slow and arduous process. Uh, Trez likes to say these skills are really simple, but they're not easy. They're very, very difficult to put into practice. And that's why we leverage our family ambassadors to help provide ongoing coaching and emotional support to the families who are learning how to apply these new strategies with their loved ones. We know undoubtedly that families are part of the recovery process, but we have a lot of difficulties in leveraging them as such. And one of the biggest challenges that we see is how families' roles have changed as our mental health system has changed over the decades. So, what you'll see on the left hand side of the screen is a little snippet from a New York Times article in 1987 after shutting down most long-term psychiatric institutions. We have a lack of integrated community mental health systems that were there to support individuals with serious mental illness in the community. And of course, the care fell to the families. And so we see headlines like families become the doctors, which is an absolute travesty. Right? Families are not healthcare providers. They have a unique and an important role in the health, wellness, and recovery of their loved ones. And they need to be supported. You all need to be supported so that you have the information and tools that you need to perform that role effectively. But that's clearly not been the case. And in fact, despite families' very clear involvement in day to day illness management, many caregivers have reported that they are excluded from care conversations. And there was a report that was conducted by the Interdepartmental Serious Mental Illness Coordinating Committee, which is comprised of members from different government agencies. They surveyed all of the states and territories in the United States and asked state mental health administrators how often or what is the accessibility of these different interventions for serious mental illness in your state. 98% of families in the United States, based on this survey data, this national audit, do not receive access to a family intervention for psychosis. And just to be clear, when we talk about family interventions for psychosis, that includes basic psychoeducation about what psychosis is, what are the different kinds of schizophrenia spectrum disorders or affective psychotic diagnoses, and what's the prognosis, and how do we improve the prognosis. So even basic psychoeducation, which every family member should be receiving, it's just not happening. And this is really counterproductive to recovery because all of the research tells us that when we engage family members in the care of their loved one with psychosis, we see improved treatment adherence, we see reductions in relapse, we see fewer hospital admissions, and when they do happen, we tend to have shorter inpatient stays, better treatment outcomes, better work and role performance on the part of the individual with psychosis, an overall improvement in quality of life, reductions in substance use, even reductions in mortality. And this was a 10-year longitudinal study that was published in 2015 of first episode psychosis service users that found that the risk of unnatural death in service users with psychosis was reduced by 90% in those with family involvement. That is a profound finding. And then I was involved in a systematic review that was conducted with the Agency of Health Research Quality, published by that agency in 2017, and then again as a journal article in 2022. And we looked at the all of the research that we could find that met our inclusion criteria for both pharmacologic and psychosocial interventions for psychosis. And what we found was that our effect sizes, meaning the clinical impact of family interventions for psychosis, was comparable to what we see in most second generation antipsychotics, with the exception of Clozaril, which just kind of blows them all away. So that's really, really profound finding. And we also know that part of the comprehensive treatment of psychotic disorders should include a talk therapy like CBT for psychosis, cognitive behavioral therapy for psychosis. CBT for psychosis is not the only indicated psychotherapy for psychosis. It is the intervention with the largest evidence base. And yet we know it is just as difficult to access as a family intervention for psychosis. Psychosis REACH really is the hybrid of these two interventions. It is a CBT for psychosis informed family intervention. And this is really unique because most of our traditional family interventions for psychosis have really relied on a lot of primarily psychoeducation. And this is really taking it one step further to say, we actually are going to teach you some skills, not to put you in the role of doctor or therapist, but to help improve communication, problem solving, coping, and just the relationship that the loved one has with with the individual impacted by psychosis. So when we talk about Psychosis REACH, I want you to think about this three-legged stool because every one of these three components is just as critical as the other. Although we do focus a lot on number three, those cognitive behavioral techniques for psychosis, which I'll talk about in just a moment. But we also really want to make sure that we are providing that psychoeducation that we know every single family member should be receiving. We need to talk about caregiver self-care, which is always a buzzword, but we also need to talk about community care, and I'll just share more about that in a minute. These are the three components of the model. The family members that we engage as family ambassadors are really instrumental in reinforcing the importance of caregiver self-care and community care and what that looks like for them. And then also helping to provide models and practice opportunities for the cognitive behavioral techniques that we teach them. So very briefly, and this is, meant to just be a brief overview, but I will say Psychosis REACH, because I have done a lot of work to engage philanthropy and families like you are in a position to be able to support this program. This training has been free for as long as it's been in existence. So if this feels like a good fit for you, you can go onto the psychosisreach.org website and you can sign up to be part of the next training cohort. So just very briefly, recovery-oriented psychoeducation is absolutely critical because so often stigma is a huge factor in maintaining both psychosis and also some of the impacts that we see in caregiver mental health, right? And partly it's because when people feel the stigma of an illness or a condition, they isolate, they don't talk about it, and it's an incredible stressor that they're carrying with them wherever they go. And so one of the things that we do in Psychosis REACH is we actually normalize, and this normalization that we do is actually quite authentic, right? And it's empirical too. When we look to the literature, we find a lot of evidence that things like hearing whispers or even hearing voices or sounds that other people don't hear, or having strongly held beliefs that other people don't agree with, or even what we think of as thought disorder, which is, difficulty expressing ourselves in an organized fashion, that we see these on a spectrum. And so we can start to normalize some of these experiences for the family members, and even normalize the fact that psychosis is much more common than we're led to believe, and that psychosis arcs toward recovery. And there's a lot of reason for hope. And that's sort of the second piece of psychoeducation is we know that family members are not exposed to all of the hopeful aspects about a psychotic diagnosis. They're exposed to the doom and gloom. And so we expose them to what does the longitudinal research say, especially the international data, and and what does the research say about the trajectory of recovery in the context of comprehensive care, particularly early on in the course of the illness. And that really gives our family members a lot of empirical cause for hope. We want to share information on where to access care in a supportive community. We want to provide sources so that they can learn more about the treatments that are indicated. So we will literally provide our family members with a copy of the family version of the National Schizophrenia Practice Guidelines, because we know that you all are your loved ones' best and most effective advocates. And so oftentimes families have to go and advocate for their loved ones' care, and we can help them do a better job of that by telling them what they should be advocating for. All right, next is that self and community care. And this is actually based on a lot of research, decades of research that suggests that caregivers' emotional well being influences their loved ones' well being, right? We are all in these reciprocal relationships. And when we're stressed out, it stresses out people in our immediate environment. And so we're actually helping caregivers to down regulate their own emotions and help them manage their own stress. We also know that at the extreme end, high levels of tension, anxiety, criticism, or hostility when expressed toward the individual with psychosis can increase the risk of relapse and rehospitalization. So a lot of the strategies that we're teaching our family members are really intended to help increase the emotional neutrality in the home, right, to the extent possible. What can you do in the moment when you get dysregulated? And I think some of our strategies, which I'll talk about in a minute, you can see how we provide these windows of opportunity for caregivers to pause, try to regulate their own emotions if they can in that moment, and then to respond. Or if they can't regulate their own emotions in that moment, to be able to say something, to be able to skillfully get out of that situation and come back to it later. And we know that caregivers need support. And so the other part of this work is really helping them to build a community of people who know, a community of caring, a community of concern. And that, again, is really unique to Psychosis REACH. We are teaching self-care strategies that are empirically based on cognitive behavioral therapy. We're also teaching strategies that have been developed by our Psychosis REACH family ambassadors. And as an example of that, one of our family ambassadors, Karen Schilde, has developed this coping card that is pocket sized and meant to be able to, use in the moment when needed. We also communicate the importance of that community, and we can foster that community through the Psychosis REACH Family Ambassador Network. So let's talk about those cognitive behavioral techniques for psychosis. We have an acronym called FIRST, and the FIRST acronym is actually intended to remind families to try these skills first, right? Remember, we are disrupting old behavior patterns and we are replacing them with these new ones. So our F is for falling back on your relationship. Our I is inquiring curiously, meaning dropping assumptions and asking questions about their loved one's perspectives or experience, reviewing the information and putting it together. S is for skill development, and T is trying out the skill and getting feedback. And if we have any clinicians on the call, I think I saw maybe one person endorsed being a clinician. You may recognize these skills as the cardinal skills, big bucket skills in cognitive behavioral therapy, right? Our first is developing a good therapeutic alliance. Our I is our Socratic dialogue. Our R is formulating the problem, right? Old school psychotherapeutic modalities like Freudian psychoanalysis, the therapist has a formulation of what contributed to the problem and what's maintaining the problem, but they don't necessarily share that with the patient. Cognitive behavioral therapy is really, it relies on this collaborative empirical approach. And so we teach family members how to develop a hypothesis about what's contributing to, let's say, their loved one's distress in the moment, or a long-standing delusion, and then how to share that formulation with their loved one so that they and their loved one can get on the same page, and then collaboratively develop a skill S that they can try to help disrupt this cycle that they're in. And then they can do that skill together and then figure out, if it worked, how can we keep doing this, or how can we even generalize that skill into new environments. And we really want folks to think about the first skills in this pyramid, because our F skills are the bedrock. If you don't have that relationship intact, you can't do any of these higher level skills. And so for some of our family members who maybe they have this conflict that's been going on for years, they may need to stay in F for quite some time before they're able to move forward into the higher level skills. And we teach them how to do that, right? What does empathic listening sound like? What does befriending look like for your loved one? How can you normalize your loved one's experience without maybe colluding with an unshared belief or delusion? And then how can you get on the same page? How can you develop some shared goals? That's an incredibly difficult skill for some of our family members who have been at odds with their loved one for some time. And then we can proceed. And there are times where we also will tell our family members, you may have to take a step back. You may be in S or even T, and then something, there's a wrench that gets thrown in, and you're right back at F, and that's okay. That's part of the process. So this is an example. I'm going to walk you through this because I know there's a lot of boxes and arrows here. But this is an example of how we might help family members to start to figure out what are the inroads in a problem that seems to be just so challenging that they're just not sure how to proceed. So in this case, let's say Doug is the son. We're working with one or both parents. And Doug is hearing voices, and he believes that the voices are from the police. So that's the situation at the top. And what's really, really important about that box is that we want to distill the situation into just the facts. So not your loved one's interpretation of what's going on, which is that the voices are from the police who are trying to torture them, not your interpretation of what's going on, which is that the voices are a symptom of schizophrenia, but simply the experience of hearing the voices. And then the interpretation is that top box that says the voice are trying to torture me. That's your loved one's take on what's happening. When they have that interpretation of the voices, they feel angry, they feel guilty, and they might feel a little bit hopeful, they've said, since the voices stop before Doug goes to sleep at night. What does Doug do in response to the belief that the voices are trying to torture him? Or excuse me, the police are trying to torture him. He engages in a lot of worry behavior. Maybe he paces. Maybe he just gets stuck on that worry hamster wheel. He's constantly hypervigilant, monitoring, looking out his window. And he is really, really concerned about technology and that technology may be monitoring him. One of the things that we need to do is just take a step back and see the bigger picture here and look at the theme. And the theme of this thought is that Doug feels unsafe. Now, a family member is going to have a really hard time with having empathy for this idea that the police are, in your head and they're trying to torture you on purpose. You're being targeted for some reason. That's not likely to be experience that they have had, and not something that they think is happening. But they can certainly empathize with the feeling of being unsafe and the anger that that might bring up for somebody who's dealing with that a lot. And so already we've started to build some understanding, and we can see how that understanding breeds compassion. So the next thing is we want to think about, okay, let's make sense of these behaviors and help Doug make sense of these behaviors, right? And so on the one hand, these behaviors create a sense of relief in the moment, right? Remember, he feels a little bit hopeful. And a lot of people who engage in worry behavior believe that the worry does help keep them safe, that the vigilance helps keep them safe. But I think what we have to ask is, given that this is something that has been coming up for you for years and you still feel unsafe, maybe it's not 100% true that these behaviors are as helpful as you think that they are. So we could think about maybe doing something different the next time you start to worry about the police. And then the next thing we want to focus on with the family members is the emotion, right? Emotions like guilt, anger, shame, sadness, and self stigma really exacerbate the experience of psychosis. And so, we can think about, maybe there are interventions that we can do on this side of the diagram to help the individual experiencing it start to get some relief from these really distressing emotions. So when we blow this diagram up, this is kind of our R here in the first skills. When we can help family members start to lay all of this information out, we've already got some points of intervention, right? And mind you, we're actually not trying to change the belief yet, right? That might be something that takes some time to be able to change. But because all of these arrows are flowing in both directions, what that tells us is, if I can change one part of this diagram, then I will have a domino effect on the other parts of the diagram. And maybe that's not going to look like the person saying, you know what? I actually don't think it's the police who are in my head. But what we do tend to see is that reducing the strength of the conviction, or the amount of preoccupation, or the intensity of the belief, or how much that belief is impacting that person's behavior or distress, that does happen incrementally over time and has a huge impact on their recovery trajectory and the pace of their recovery. So what I want to leave you with before we start to dive into some Q&A is some words of wisdom from a very special family ambassador. She was not only part of our inaugural cohort of Psychosis REACH family ambassadors and the training, but she also was really responsible for getting Psychosis REACH launched in the first place. So she's a Washington State resident and family member, and she had attended a NAMI presentation by Doctors Doug Turkington and David Kingdon, who are treatment developers for CBT for psychosis. And in this presentation, they said, we can teach family members these skills so that they can be more effective with their loved ones. And she came back to me and she said, we have to do this. We have to bring this to Washington. And that was really what ignited the Psychosis REACH spark. So she has used these methods herself. She coaches other family members in these methods. Let's hear from her.
You're not alone in this. There are people before you and people after you that are going to experience this, and it will be hard at times, but there will be great joy. It's a different way that you thought your child might grow up to be, but it has its blessings and wonderfulness. And the people that you meet through this journey will be so special to you, and that we're there. We're a community, willing to be there. And I'm just grateful that we had CBTP come here and to be involved in this, and how much hope there is.
And Marianne wanted to be here today, but was unable. So
You're not
I'm
alone.
glad that we could have her voice here with us. So I'm just going to leave this up for a moment to let people see what our websites are, and I will transition things back to Dr. McCarthy for our Q&A.
All right. Thank you so much for that wonderful presentation. And so for our audience, if you have any questions at all, please feel free to put them in the Q&A or the chat, and we would be happy to address them as we go. All right. So, to kick off our discussion, one of the first questions that I have for you, Sarah, is, how did you first get involved with developing Psychosis Reach? What drew you to this idea of working with family ambassadors like the one that we just heard from in terms of adapting cognitive behavioral therapy for psychosis for caregivers?
Yeah, well, you heard a little bit about it with Marianne's involvement. I
Mhm.
would say it was really consistent, though, with my professional mission. So I have worked in state hospitals, I've worked in private psychiatric units, I've worked in assertive community treatment teams, outpatient settings all over the country, actually. I've worked in 4 different states on both coasts. And what I was observing was consistent was just the lack of access to evidence-based care for psychosis and comprehensive care in particular, which is what we know works best for folks with psychotic disorders.
Mhm.
And I really felt like the only way that we're going to address this problem is if we create a mental health service corps, and we have to engage the community as part of that service corps, right? We are definitely not going to train our way out of this gap. We have to really use this method that's actually quite common in global mental health, which is called task sharing or task shifting. And the idea here is that we can take a specialty service like psychotherapy or like medication delivery, and we can task other people who don't have that specialized level of training to be able to do elements of that. And so Psychosis Reach really is a task shifting or task sharing model. I think it's more appropriately sharing because we're not asking families to be the therapist, but
Right.
we are asking families to reinforce skills at home and maybe even create this skills culture at home.
Mhm.
And when I say skills culture, I mean that's because the family members are also using this skill, right? It is
Of course.
not just, these are not just skills for people with psychotic disorders or other SMI. These are skills that benefit all of us. And
Mhm.
so that was really consistent with my mission. And from there, I just had the benefit of the right partners, right? To be able to partner with Doug Turkington and Kate
Mhm.
Hardy, and really think about what do we know about what will translate to a family member, that where we can train them up in this in a reasonable time frame where they don't have to go back for night classes for six
Yeah.
months, right? And so
Mhm.
that was how it came about, and it started off as a in-person 8-hour workshop that we held in Seattle. And immediately just hearing, both getting the data from that workshop, but also hearing from family members and seeing the tears and seeing the reaction,
Mhm.
I knew that we had to ensure that this could get to every family member around the world who needed it.
Thank you so much for one, being involved in this, and two, for that context. So, one of the questions that our audience is asking is, do you have any advice for families who encounter inpatient clinicians who do not involve the family? So what do we do if we're kind of feeling like we might be starting from scratch with that barrier to family services?
Yes. So the primary source document that I want you all to get, and it's freely available online, is the American Psychiatric Association's practice guidelines for schizophrenia spectrum disorders. And if you go to the APA's website, if you just put that into Google, it'll take you to the website and you will find a link to a family and caregiver version of that manual. And it very clearly states that families should be involved in care. it also, and this is a new addition, so that was made to the updated 2020 guidelines. It also says that medications are a complement to psychosocial interventions. And that is a huge paradigm shift, right? We have our psychiatric system has been rooted in this biomedical model. And so for decades, especially with serious mental illness, our clinicians have been trained to believe that medications are the holy grail of treatment. But what we know now is that medications are as effective as psychosocial interventions and vice versa. And so the best kind of care is one that is a package of therapy, medications, or other biological interventions, as well as family support. And the family cannot support their loved one if they're excluded from care. Now, HIPAA is the law of the land, and so many clinicians will cite HIPAA as a reason to exclude families from care. And in some cases, that is absolutely them following the law and their institutional regulations. Um, However, there's a couple things that you should know. One is that HIPAA does not preclude clinicians from receiving information. So you can share and should share relevant information. One of the things that we see that can be so disruptive to the recovery process is if your loved one is hospitalized and the inpatient staff has no idea what medications have been trialed, or they don't know what the signs of agitation look like for your loved one, right? And so you should be calling the unit and saying, just giving them as much information as they need to do right by your loved one. And the other thing to know about HIPAA is that you can doesn't have to be all or nothing. And so
Mm-hmm.
you can share with your loved one, or the care team can share with your loved one, that you can consent to have family involved in care, but you can also say how you want them involved in care and how you don't. And
That's
so
such
when
a
I'm
good
doing
point.
therapy with somebody, I will say, when I bring a family member into a session, I'll say, here's my plan of what I want to discuss when your family member's in the room. Do you have any concerns about me discussing those things? Is there anything that's off the table that I should know about?
Mm-hmm.
So the more discretion and voice we can give the identified patient, the more effective we can be.
Thank you for sharing. So, you know, oh, one person just asked, could you please repeat the name of the document as
Yes.
that source from EPA that you had mentioned?
Yes, it is the American Psychiatric Association's Schizophrenia Practice Guidelines. And there is a version for family members, family and caregivers.
Great, thank you. I'm just popping that in the Q&A response for people who might want to jot that down as well. So another person asks, do you have advice on how someone can help their spouse perhaps lose the embarrassment or deal with the stigma of their son's new diagnosis? This one person says that they're ready to start Psychosis REACH, but the spouse is not. Could one family member do it without another family member's support and still be effective? What do you
Yeah,
think?
that's a great question. Absolutely. I would say that's actually quite common. We'll see one family member will do the training, and then they'll just start sharing what they've learned with another family member, and then that person might join in a subsequent cycle. And so I would absolutely do that. I think the other thing is, if we think about um, who has the gravitational pull here, right? You don't want to, he's really struggling a lot with the diagnosis. There's grief, there's shame, right? And you can actually create a gravitational pull towards other perspectives or other reactions. But I think he also just needs to be able to process the emotions that he has. And I think one way that you might actually pitch Psychosis REACH to him is that it will connect you with other family members who have
Mm,
been in our shoes. And many of them are also processing these same emotions. And these are emotions that people don't want to talk about, but
Right.
they're there. They're there. And so being able to connect with a family ambassador who can validate those emotions and talk about how they worked through them or continue to work through them can
Mhm.
be really healing for him, even if he's not ready to take up the practical skills for the loved one.
Thank you. I think that really helps people see maybe where they can meet their loved ones, where they're at, whether that be the person with lived experience with psychosis or other family members as well. So, another um, attendee asks about a situation where their daughter has a history of psychosis. However, this daughter has had some bad experiences where a clinician that she had been working with sent the police to the daughter's house and pepper sprayed her and then got her locked up for days at a psychiatric hospital. And as a result, the daughter is very reluctant to go seek help again. And so the family member is interested in how they might be able to get this daughter help to maybe see a therapist and find one that she can work with and trust based on that history. Um, so, any advice for that type of situation?
Yes. First of all, it's just, I'm so sorry to hear that she had that experience. That can be a really, really just adverse or even traumatic experience to have. And so I totally understand the reluctance to try again. And I am so glad. I think this is a perfect example of how family members are really a lifeline here. And so I am so heartened to hear that she has this relationship with you, that you can be there for her. And also, that's a lot to carry on your shoulders. So one thing I would say is, you know, we can always, in Psychosis Reach, we talk about what to validate, right? And so one of the highest levels of validation we could do is to say, God, if I were in your shoes, I would feel the same way. It would be really hard for me to trust again, right? That in and of itself can just help bring defenses down and help you guys kind of get on the same page. And then you could say, when you're ready, I wonder if we could talk about what are some different strategies to make sure that we can find somebody who is a good fit for you. And, then you kind of open the door to be able to collaboratively problem solve or brainstorm. But I think first, starting with validation and getting on the same page, as just to kind of create that alliance with each other and that shared goal is a
Mhm.
good starting point.
Yeah, thank you so much. So, someone asks an important question to make sure that we're all on the same page. So, you use the term psychosis. I've used the term psychosis. Could you please briefly define what you mean by psychosis, and what are some of the mental experiences that people might see in their loved one if they are experiencing psychosis and they may not know what name to give it or may not realize that this perhaps is psychosis.
Sure. Yeah. So psychosis is generally considered to be a break with reality where the person has their own idiosyncratic version of reality that's not aligned with the kind of shared understanding or perceptual experiences of their culture, right? So there's two broad categories of psychosis. One are positive symptoms of psychosis, and they're not called positive because they are enjoyable to have, right? They can be quite scary. They're called positive symptoms because these are thought of as things that are um, sort of an addition to the typical human experience, right? These are things that people are not typically experiencing in their day-to-day lives, and that is things like perceptual disturbances to the point where they're experiencing hallucinations. Auditory hallucinations in the form of voices is the most common, but people can also experience visual hallucinations, olfactory hallucinations, tactile, right? All the five senses. Delusions, which are strongly held beliefs that are not held by others in that culture and are resistant to disconfirmation. And so most often the kinds of delusions that we see in schizophrenia spectrum disorders are paranoid or persecutory delusions. And there's a lot of fear and anxiety around the belief that they're being harmed by other people or threatened by other people. We might also see other things there, like ideas of reference, believing that TV or famous people or radio are referring to them, or just kind of this magical thinking, right? These ideas that are kind of a little bit out of the ordinary and fantastical. And then we have what are called negative symptoms, which are the absence of things that are typical to the human experience. So the kind of buckets of negative symptoms are affect, right? It's like it's our the tone of our voice changing. It's our facial expressions changing, the way that I use my hands when I speak. Those are the kinds of things that really communicate help us communicate and also communicate how we're feeling. And people with negative symptoms have a very difficult time with emotional expression. They may be quite stone faced and not get animated at all. And then the other real challenge that we see with negative symptoms is motivation. It is a Herculean task just to be able to get out of bed and fix yourself breakfast when you're struggling with negative symptoms. And so there's a lot of strategies within cognitive behavioral therapy that are trying to help to uh, work with both the positive and negative symptoms of psychosis, and do so, quite successfully. But the negative symptoms can be the hardest to treat, and they're actually what family members say are the most distressing, because it just feels like your family member is inaccessible. It's so hard to see through those negative symptoms.
Thank you so much for that overview. That is very helpful. And somebody asks about, looking for people to work with who do the work that you all are doing. And just to clarify, correct me if I'm wrong, Psychosis REACH training is online for people still, correct? Or is there an
That's correct.
in-person component?
There's not an in-person component.
Okay.
We are 100% virtual.
Mhm.
Uh, that being said, yeah, so let me share a little bit about that, and then I'll kind of give the caveat. So our training model is you get when you sign up for a training, you're signing up to be part of a cohort. We allow a maximum of 100 people to join each cohort. You get access to an online course that has about 5 hours worth of content all the way through, but you have 3 months to complete that training. So you could do it at your own pace. And then once you've completed that training, we have a live workshop where you'll get on it's kind of like this, except we don't have it webinar style. We want families to be able to see each other. And then we have a family ambassador and a clinician who will go through and do what we call real plays. And we call them real plays because we are demonstrating each of those first skills using real scenarios from our family ambassadors' lives. And so people get an opportunity to see what do FIRS and T skills look like in these scenarios with a loved one. And then from there, they have access to our network of Psychosis REACH family ambassadors. And so if there was one in Boston, they could reach out to that person. But usually you're meeting with the family ambassadors online, through Zoom or such anyway. So you could access a family ambassador for ongoing coaching and support. And usually it's about 6 weeks that they'll work
Mm.
with a family member. The caveat was, it's really important to me, just sort of as a values, as part of my value system, that we are not developing an intervention and then waiting until there's been 10 years of research on that intervention and then saying, okay, now let's do some cultural adaptations. Let's see how we can make this work for Black families and for Asian families and for, what we need to do is right from the get-go be able to have this intervention work for local communities.
Mhm.
And so, as part of our dissemination model, you can always come and join a University of Washington led Psychosis REACH training. But we also want to partner with local groups like McLean or, like maybe even at the state level, to be able to develop a Psychosis REACH training hub in a region where some of that local adaptation can take place, whether that's changing the language that it's delivered in or changing some of the language that we use in the interventions to make it resonate for people more. So we have one Psychosis REACH training hub that is just getting off the ground now, and that's in the state of Michigan. We have some other states that are interested in becoming a Psychosis REACH training hub as well. And if you're interested in that, there's a little bit of information on our website, but you can also reach out to us.
Great. Thank you so much. So I think that's all the time we have for questions right now. And so I'll just share a few slides and information for our closing remarks. Okay, so first, thank you everyone for joining us. And in terms of local McLean resources, we always like to share those for those who are in the Massachusetts area. We have a number of different family support groups that are available to folks. And then also, I would love to have folks take a couple of minutes right here at the end to share what you think of this webinar. I really enjoyed learning even more about the Psychosis REACH model. And so I'm going to put this in the chat now. And then I'm also going to share in a moment the resource sheet that gets updated every month, based on resources that we're learning about that could be relevant to you and your family anywhere in the United States or potentially beyond. So let me put that in the chat. Okay, and so that's a PDF. So feel free to take a look at that. Feel free to let us know if you have suggestions about that as well. And while people are filling out those surveys, Sarah, could you share when the next training is for Psychosis REACH?
So we actually have a cohort that's getting their live event tomorrow. So that cohort
Oh,
is
exciting.
full and on their way. And then within the next 2 weeks, we'll be opening things up for the next cohort, and they'll have their live event in December.
Okay, excellent. Thank you so much. And so in terms of what is coming up for us, I'd just like to thank all the people who have made the research and quality improvement project for the Crafting Support Project possible. And our next family webinar will be next month, Thursday, October 10th from 5 to 6 p.m. Eastern Time. And we'll be featuring a number of our psychiatrists and a nurse practitioner to speak on how to talk about medications for psychotic disorders and more. Because I think one of the things that often comes up in conversation for oneself or certainly with family members, and I think this may also potentially come up in some of the Psychosis REACH live examples is, how to talk to people about treatment. And one of those treatments includes medication as well, in addition to the very useful psychosocial interventions that I'm so glad that you shared about and highlighted the research that really emphasizes their value. So if anyone has questions for me, feel free to get in touch. My email and phone number are here. And I would just like to thank you all for your time being with us and Dr. Kopelovich for your expertise. Thank you so much. Okay, have a good night.
Thank you.